If you enjoy listening to clinical conversations, why not become a member of the Royal College of Physicians of Edinburgh? Our membership provides you with access to the RCPE educational portal, the live evening medical updates, and you have options to view the symposia both in person or online. If you would like to learn more about this, please go to the Royal College of Physicians of Edinburgh website.
Hello and welcome to the Royal College of Physicians Edinburgh Clinical Conversations podcast. My name is Ben Warner and I'm a Respiratory Medicine Specialty Registrar in the east of Scotland, currently out of programme while I complete a PhD in Multimorbidity in Malawi. Today I'm delighted to be joined by Professor Tom Fardon, a consultant in Respiratory and General Internal Medicine at NHS Tayside and Honorary Professor at the University of Dundee, as well as the clinical lead for the Respiratory Specialty Delivery Group with the Scottish Government. Tom graduated from Cambridge in 1999 and was awarded his MD from Cambridge in 2008, winning the Ralph Nobel Prize for his thesis, Optimizing Anti-Inflammatory Therapy in Atopic Asthma. And he is joining me today to talk all things asthma. Tom, welcome.
Thanks very much, Ben, for inviting me along. And it's nice to see you all the way in Malawi. Nice to catch up.
Indeed. Thanks very much. So, Tom, before we get into the meat of the discussions around asthma, I just wondered if we could start with you telling us a bit about your background and perhaps how you became interested in asthma.
Yeah, so I suppose my interest in asthma goes all the way back to being a child. In the 1980s, I was a breathless kid and was, of course, told I had asthma and was given a brown inhaler and a blue inhaler. And then, as often happens, I was told I'd grown out of it. And then you fast forward to medical school, when I learned a little bit more about asthma, then fell into being a respiratory trainee almost by accident, and then was inspired to do an MD by my consultant at the time, and went to work with Professor Brian Litworth, who is still a colleague now in Tayside, doing asthma research. And I suppose that captured my imagination at the time and my interest in what is the commonest respiratory illness in every region. And I was struck at the time, and still am, by the impact asthma has on people. The attitude that many people have that it's a benign illness and doesn't really have much impact. It's straightforward. It's still brown inhaler, blue inhaler. But actually, there's a great deal of complexity to asthma. It's important that we know more about it. It's important to generalists. Everyone will see asthma. And it's important to us as specialists and super specialists, because the field is advancing, it's changing, it's moving on. And what we know about asthma now compared to when I did my MD nearly 20 years ago is huge. And the way we treat severe asthma particularly has changed dramatically in that time. So I'm still fascinated by asthma, and hopefully we can have a conversation today about how the treatment of asthma has changed.
Perfect. Absolutely. I think that's a really nice summary that everybody knows what asthma is, but then actually when you try and put your finger on it, it's a very hard thing to pin down. So hopefully we can explore some of that as we go. So perhaps to get us warmed up and to start with something that's a bit less of a grey area, I thought it might be helpful to start with what many see as one of the scariest aspects of asthma, which is the management of an acute severe asthma exacerbation. And perhaps we could talk through a quick case and discuss the approach to such a patient. So as a little vignette, if we imagine that we have a 24-year-old female patient who presents to the emergency department, acutely short of breath and wheezy, and she's been feeling unwell for the last 3 days. She's got a history of asthma, but hasn't been to her GP for over a year and has been borrowing her brother's blue inhaler, but it ran out yesterday. She hasn't been able to get to her GP because she's been really struggling with her mental health after she gave birth to her first baby last year. And she works part-time in a restaurant kitchen and smokes 20 cigarettes a day. So before we even meet the patient, can I ask what might be going through your mind with this patient?
The case you highlight here is not untypical. We know from the NRAD report from more than 10 years ago now, that's the National Report into Asthma Deaths, that people do still die from asthma. And the people who are most likely to die are those people who don't engage with primary care services, whether that's either deliberately or because of circumstance, but they're not engaging with primary care services. People who don't use maintenance therapy, so they're relying on reliever therapy, they take their blue inhaler, the reliever, but don't take the brown inhaler, the preventer. People who smoke is fairly self-evident, and particularly people who have psychosocial issues, mental health problems, people who live in a background of poverty. These are very strong predictors of a poor outcome. So as soon as you tell me this story, I immediately think this is a person who's actually at very high risk of death. And they present late. They struggle on, they multi-dose their short-acting beta agonists. They don't engage with primary care. They don't have an asthma action plan. They're not clued into what the trigger points are. And usually they crash into emergency departments. And there's no wonder that you tee this up as being scary. This is a frightening situation. She's 24, she's got a small child, and she suddenly crashes into ED, and immediately the alarm bells. This woman is at very high risk of death.
Absolutely. As you said, I think there's things to look for before we even meet the patient, and the BTS guidelines, I think, really nicely spell out exactly what you're saying about red flags for who's really at high risk. So we're going in there pretty wary of what might happen. And when we see the patient, she's been in ED for an hour and a half. She's had back-to-back salbutamol nebulizers and an ipratropium nebulizer. She's had some oral prednisolone, but she threw it back up straight away. She's currently on an oxygen-driven nebulizer, and she's sitting up in a tripod position on a trolley in resus. So sounds like the ED team have been following the BTS sign guidelines. They've got her on oxygen early. They've got her on high-dose inhaled short-acting beta agonist. How would you go about your clinical assessment of her from here?
So as you say, the ED department are following the process as always, your ABC approach to the acutely unwell patient. Oxygen when required. Typically, people with asthma can breathe in perfectly well, and their oxygenation is not generally an issue. And I think if oxygenation is an issue, that's a very early warning sign that something is about to catastrophically go wrong. And I think taking a step back and looking at those objective measurements, the BTS sign guideline has for generations of guideline had those markers that say, is this a moderate, severe, life-threatening exacerbation? And I think as you come in and take a step back, you've said tripod position. What's the respiratory rate? Is it starting to fall? Are there signs of exhaustion and tiring? Are they genuinely hypoxemic? Are their oxygen saturations genuinely falling now? And critically, what's their CO2? And our options for severe asthma exacerbations, life-threatening exacerbations, are fairly limited. Bronchodilators, steroids. We don't have a lot of options for treating severe asthma. Bronchodilators are the front door. Steroids, either orally or intramuscular intravenously. Intravenous magnesium is very helpful, but it's not an instant reaction treatment. You need to start that early. But ultimately, when the patient starts to deteriorate and we start to see those signs of life-threatening exacerbation, bradycardia, dropping in respiratory rate, drowsiness, a silent chest, it's about calling critical care colleagues, ICU anaesthetists. And what I always try to tell the trainees I work with is that if you're thinking about calling ICU, you should be calling ICU. And best to have them in the room to have the conversation than be thinking 10 minutes later, I wish I'd called ICU. And taking someone to ICU for observation, pending intubation, is a perfectly reasonable thing to do. And I've been lucky here. I think that we've been able to cultivate a relationship with our ICU consultant team that we can do that, and that you don't have to be intubated to go to intensive care. Because patients with severe asthma deteriorate very, very quickly. They get to the point where they suddenly deteriorate. And of course, often many of them are young people. They have a lot of reserve and they can compensate and they can cope. But when that goes, they drop off a cliff so quickly. And it is frightening. And I think it's frightening to us because there's not a lot we can do. We give the back-to-back nebs, we give the magnesium with the steroids on board, and we have to watch and wait. But any side of deterioration, it's that call for your ICU colleague.
Absolutely. So I suppose thinking about those signs, and I think you highlighted a number of them that are in the guideline for categorizing acute, severe, life-threatening, near-fatal, and the role of ABGs, I think people can sometimes be quite... Well, I think there are different camps perhaps about doing ABGs on every sick patient or being much more conservative about when we do an ABG. Do you have a threshold or an idea in mind for this patient?
I'm generally an ABG enthusiast. I think that we have SATS probes to look at oxygenation. I'm very happy with that, but you don't know what someone's CO2 is. And in the situation of a young person with a life-threatening disease, you shouldn't be guessing. And I think there are traps here that someone's respiratory rate starts to fall and they become less wheezy. And you think, well, that's okay. They're getting better, when actually they're getting worse. And you can't tell what someone's CO2 is until it's so high that they become lethargic and start to become narcotized. And a blood gas tells you so much. And we always teach that a normal CO2 in someone with a life-threatening or severe asthma attack is concerning. And I think that still holds true. So blood gases, I think, are very important because it tells you information you can't find out in any other way. So if I'm called down to the resus room or down to acute medicine for someone with a severe asthma attack, a lot of information I glean from looking at the patient straight away, but the first thing I'm asking for is what is the latest blood gas?
Absolutely. And I suppose the oxygenation can be masked, as you're saying, if someone's on oxygen-driven NEBs, their true hypoxia is not going to be revealed just on a SATS probe.
And there is a tendency in our emergency services to give oxygen to everyone. And that's not necessarily it, but it does give people relief. People feel better on oxygen often. But yeah, absolutely, your SATs can be masked. Your CO2, you can't tell without doing the gas. And there's often a lot going on in that room. There's a lot of heightened emotions and anxiety and stress going on in a resus room with a young person who we're all worried is about to have a very poor outcome. So objective measures are very helpful.
You had mentioned a couple of other therapies that are perhaps more second line or really to give you something to do while you're waiting for the patient to get better or the critical care team to arrive. But in terms of things like IV magnesium, IV aminophylline, where do they sit in your toolkit?
I think IV magnesium is genuinely useful. And I think we do see people turn around quite quickly having been given IV magnesium. And you can give a repeat second dose, which is helpful. Nebulized magnesium not been shown to be of any benefit. And I think we've all moved away from nebulized magnesium now. I think if you're at the stage of giving people intravenous aminophylline, I think a conversation with intensive care really should be happening. I think there are some sort of super responders to aminophylline. I think most people would say that we've seen that happen. But likewise, there are people who have really no benefit from it at all, lots of side effects, causes quite a marked tachycardia in patients who are already tachycardic. It can mask other signs of bradycardia, which is a worrying sign in this situation. And it takes a while to set up. It takes a while to run in. The levels take a long time to come up. And I think, as you suggest, it may well be delaying the important thing. So the idea of we'll run the aminophylline for a bit and see if that changes things, I caution against that, particularly the patient you don't know and you don't know if they respond to this, because it can delay definitive treatment. And the same for CPAP. It was a long time ago when I was an SHO, but well, perhaps CPAP would be a good thing because we can bridge people to intubation or we can avoid intubation. But I think that's been fairly long since disproved. Forcing air into people who can't breathe out anyway is not a great idea. Pneumothorax as a complication of severe asthma attack is almost invariably a pre-terminal event, and forcing more air in worries me. So definitely no CPAP. If anyone's reaching for the CPAP machine, they should be reaching for the phone to call ICU.
And I suppose in terms of simpler things that actually might be more beneficial, IV fluids, would you generally be thinking about that with patients, thinking about tachypnea and dehydration, or indeed the potassium?
Yeah, I think that it's important not to forget that the lungs are attached to a human and other things go on. And people may well have been not well for hours, days, may be laid up in bed, not drinking, not eating. They may have other comorbidities. They may be on various drugs. They may have taken an awful lot of salbutamol. They may have taken various other bits and pieces. So I think you're right, absolutely. It's important to consider those other things. Oftentimes they're young people who can cope pretty well, but you could easily change one thing in your little vignette, and that's someone who's 56, not 24, and they may well have a lot of other comorbidities and lots of other polypharmacy, in which case that's very important to look at. So yeah, I completely agree with you, and I think normalizing physiology is always a good thing. Take the dehydrated patient and rehydrate them and fix electrolyte imbalance if you can. I think generally in a critical care situation, if in doubt, normalize physiology. So yeah, I agree.
Perfect. Okay, so perhaps this patient is one of the ones where a dose of IV magnesium seems to just get her over the hump and things start to improve. So she's admitted to the short stay medicine ward. Over the next 24 hours, she's on the mend. So I wonder, at this stage, perhaps it would be helpful to start thinking about when would you consider discharge and what needs to happen before discharge for this patient?
I think it's very important that people in this situation are seen by respiratory specialists. What has been highlighted by the report into asthma deaths and subsequent reports is that people who are seen in ED get better and go home. Sometimes they discharge themselves, sometimes they're sent away home. Or they go to a short stay unit and go home very quickly and are not seen by respiratory specialists. They have an increased risk of a poor outcome. And it's mainly because they don't get looped into the system. If we don't know about them, then we can't help them and we can't provide them with structure and support. Many of these people don't engage with primary care services, so we need to engage them in secondary care. So I think bundles are very important, and British Thoracic Society has a good system bundles which are in place for discharge. So that was updated last year and is available on the BTS website, so the BTS SAG. And I think spending time with the asthma patient who's been through what you describe as a near life-threatening episode to try to get the basics right. So are they on maintenance treatment? What are their modifiable risk factors? Smoking in this case is a really important thing. Adherence with medication. Do they have an asthma action plan? What's their inhaler technique like? So get the straightforward basic things right, because this is a teachable moment, as we talked about, isn't it? An episode where something scary has happened and an opportunity to sit with the patient and say, look, we really don't want this to happen again. These are the simple, straightforward things we can do to reduce that risk. I think you have another opportunity at this time to do more tests to try to ascertain what sort of phenotype the patient is. Or maybe we talk about that a bit later on. We talk about advanced therapies. But you have an opportunity to do the blood test, to think about imaging, to think about phenotyping, so that you can then, when they come back to clinic in a month, and people should come back to see an asthma specialist at 4 weeks later, then you have all the information ready so you can optimize treatment and provide them with better care to reduce getting admitted again. If you can identify triggers, that's helpful as well. And infective exacerbations versus inflammatory exacerbations, I think it's important to think about that. And if you can do tests during an exacerbation and then do the tests again in quiescence when they're at baseline and look for differences, that can be really helpful. There is a tendency to try to discharge people very quickly. I think we say, well, you're a lot better and you're young and you're fit, but they've been through a significant physiological insult. And I think that patience is quite important here, because we've all seen people who have seemed fine and then the next morning wake up and they're very wheezy and they're very tight. And you think, I'm glad I didn't send you home yesterday.
Absolutely. That's brilliant. There's a lot of different threads there to draw on. I think you'd mentioned about smoking cessation as one of her big risk factors, and I think we'll put a link in the podcast notes. The BTS has recently published a clinical statement on the medical management of patients with tobacco dependency, which is a really nice building blocks approach of 6 building blocks that all hospital clinicians can use to support patients to stop smoking, which would be really important for this one. I think you were just coming to the point where you say sometimes the patient is almost there, but they can have a step back. Do you have some monitoring or thresholds that you would look for to say, yes, you're ready to go home now, having done all the interventions that you mentioned and linked in with the respiratory liaison nurse, perhaps?
I think that there are some obvious things. You need to be off oxygen, and we measure peak flow. And we'd like to say that your peak flow is back above 60% of what you would expect it to be or what your previous best is. And I think the rest of it comes with experience, doesn't it? Some people are wheezy all the time, and how much are you back to your normal amount of wheeze? But the majority of people with asthma don't have any wheeze in their chest at all. And it is an unusual finding to be wheezy. And I think the stethoscope is useful here. And on day 2, you're still wheezy. That's a problem. If you're wheezy, sat in bed, not doing very much, then I think you're going to be pretty wheezy when you walk out to the car park. And there are well-known triggers, things like cold air. I remember as a house officer, long time ago, confidently discharging someone after an asthma attack because their chest was clear. And it was in the winter, and he walked out to the car park, and it was cold, and he immediately got bronchospasm and walked straight back into A&E and was readmitted. So that was a lesson for me. People are always keen to go home, aren't they? Of course they are. But I think with asthma, I think you just need to be a bit more cautious. I think you think about, is the peak flow reliably up? And are you off your nebulizers onto normal inhaled therapy? Is the chest clear? Are you able to walk about, exercise as you would normally expect? What triggers are you going back to? You're a very allergic person, you've got 2 dogs, you're going back to those dogs. I think just take a step back, take an extra beat, because someone has been through a life-threatening episode, and I think you have to be very happy together, you and the patient, that they're going to go home with confidence and stay home. So I don't think that's easy. I think there's a lot to it, and I think that a lot of that comes with time and experience, which is part of, I think, why we need to make sure that our patients are seen by respiratory specialists, and that's either the nurses who have a lot of experience or the medical team.
Okay, so we're fairly convinced this patient has asthma. I mean, it's a pretty classical presentation. However, I wonder if we could discuss a bit about patients seen perhaps less acutely, for example, in another specialty outpatient clinic, who complain of intermittent breathlessness or wheeze, or who are seen in the ambulatory assessment area. What aspects of the history would lead you to suspect asthma, and what differentials would you need to keep in mind for these less barn door presentations, thinking more on the diagnosis?
It's a great question. And this is one of the things about asthma, isn't it? That it's very common. In some epidemiological data, 25% of the population, perhaps more in New Zealand, for example, have asthma or a wheezing illness. Yet, actually, I think it's one of the hardest things to diagnose. It's a really tricky diagnosis to make in some cases. As you described, there's some barn door obvious things. A young person who's very allergic to lots of things, got hay fever, atopic dermatitis, and becomes very wheezy when they come into contact with cats. That's fairly obvious. But there are an awful lot of people who get a bit wheezy after they've had viral illnesses. There are a lot of people who are breathless. A lot of people who have wheeze all the time, often due to their breathing dynamics. And there are people who get a lot of cough, or people who get a lot of infections. And not infrequently in severe asthma clinic, when I ask people, when were you diagnosed with asthma? Why were you diagnosed with asthma? What were your symptoms? And who made the diagnosis? I think that's important. And oftentimes they'll say, well, in my 20s, 30s, I got a lot of chest infections. And then after my 4th, 5th, 6th chest infection, I was told I had asthma. And that always rings alarm bells with me. Well, chest infections are not asthma exacerbations, not always at least. And so what is it that's actually made somebody at some point say you have asthma? The BTS sign guidelines, I think, reflect this, that there is no gold standard test for asthma. There are a number of features which would lead you to think that someone is more likely to have asthma. And there are things that would make you think less likely. And they are the things that you would expect. So when you examine someone, they have wheeze, they have intermittent symptoms that have a trigger, often an allergic trigger, that variability of symptoms has been witnessed and documented in the past. And things that go against it, never have wheeze, no variability in their symptoms, no variability in their peak flow, and every time they exacerbate, you listen to their chest, they don't have wheeze. But even with all that information, the algorithm still gets us often to trial of treatment. And I think that makes it difficult for us because sometimes people respond to treatment better, particularly when you throw into the mix inhaler device, inhaler technique. Are you confident people are taking the medication? Is it getting into the right place? So I think it's a very challenging thing to do. I think the addition of some objective measurements is helpful. And I think a peak flow chart, it's very simple. It's very straightforward. It's what I was taught at medical school 30 years ago, but actually it's very helpful. And documenting diurnal variation and week-to-week variation of peak flow, to me, I think is a very useful thing to look for. You could argue that they're not very well filled in, but digital variants are helpful and you can make it easier for the patient to do it. FeNO, very helpful test. Exhaled nitric oxide. I know that not everywhere has access to it, but I think that's something we should push for to get FeNO access because, a very high FeNO would certainly push me towards thinking it's more likely that someone has asthma. And the full blood count can be helpful. Hiding in plain sight for decades has been the humble eosinophil, which actually provides us with a lot of information prognostically for asthma because it allows us to think about future treatments. And in severe asthma, the eosinophil is the pivotal part of the inflammatory pathway. And your eosinophil count predicts your exacerbation frequency, and it also predicts control of your asthma. And that's an easy, straightforward test to do. Trials of treatment, I think, is something really important. It's embedded in guidelines for a decade that the trial of treatment for asthma is inhaled corticosteroid. Yet we still see the legacy treatment of giving a short-acting beta agonist as a trial for treatment. And we need to really make sure that stops happening. Despite being in guidelines, it still happens. I think we all recognize that does happen. And trying to just get that education through to primary care is an important step in all of asthma management.
Yes, I think there's a few points there on what the guidelines say. I think it is worth people being aware that there are different guidelines, the BTS and SIGN combined guideline and the NICE guideline. And I appreciate that we are due a unified one that's meant to come out later this year, hopefully. And I know that the NICE guidelines prominently put the FeNO, the fraction expired nitric oxide, in the diagnostic pathway, which, as you say, is really good at pulling out those T2 high phenotypes, the patients with a lot of inflammation in their airways. You'd mentioned a couple of times about allergens. When would you consider testing for allergens?
Well, we do allergy testing for everyone who comes through to our severe asthma clinic. And it is useful for us because total IgE is a helpful measurement. We're looking for ABPA as much as anything else, to be honest with you, but we're looking for other complicating things. But a total IgE can be helpful. Now, when to measure a specific IgE, it can be very helpful to try to help persuade the patient who has 3 cats that they actually might be allergic to the cats. And I accept that your specific IgE, what we used to call RAS tests, and they have their false positives, they have their false negatives. But if your cat specific IgE is 90 or 100, it's very likely you're allergic to cats. Very, very likely. And if you've got 3 cats, that could be what's driving your disease. And likewise, a specific IgE of absolute 0 is pretty much going to suggest to you that allergy is not a problem. And if your specific allergy panel is very bland, so 0 across the board, birch, grass, cat, dog, everything, house dust mite as well, is very bland, that gives a different flavour to what type of asthma you have. And you've already mentioned Th2 high disease. And people that have no allergen at all, their eosinophil count is normal, and a pheno is normal. That's a very different group of people and a different approach to treating them than the Th2 high patient. So I don't recommend that everybody gets specific IgE at a blanket level of absolutely everybody, but I think if the patient has more troublesome asthma, it could be helpful. And it could be helpful to engage in a discussion about allergy, particularly for people who have pets or people who have lots of hay fever type symptoms, to persuade them to take some treatment.
That's brought us nicely onto, I think, a concept that's worth spending a bit of thought on, that of treatable traits. So the guidelines have quite a systematic approach to escalating treatment and de-escalating ultimately as required. But since 2016, there's been a bit more discussion around type of precision medicine of describing the asthma phenotype of patients with a diagnosis of asthma. And I wonder if you could perhaps just talk a bit more on the idea of treatable traits, what that means, and some examples of them within asthma.
Yeah, so we call a wide range of airways diseases asthma. It's not one disease, and anyone who's looked after people with asthma, anyone's worked in ED or acute medicine or in general practice knows this, because there's asthma and there's asthma. There's different types of asthma. And a good proportion of people with asthma have what you might call benign asthma. Probably 80% of people have mild to moderate disease, which is relatively straightforward to manage. And an inhaled corticosteroid plus minus maybe one added treatment is probably sufficient. Then you have 20% of people who have difficult to manage asthma. It's more problematic. And then this group is what I tend to focus on in secondary care. But in amongst all this, we have the idea that people have reactive airways, people have eosinophilic inflammation, and people have reversible bronchoconstriction. Now, in that triad, there is infinite number of different combinations of that. And there are some extremes. So there are people who just have eosinophilic inflammation, and people who just have twitchy airways, and people who just have bronchoconstriction. But they're pretty rare. Most people have a bit of everything. And you mix into all that what their treatable traits are. So treatable traits, I think, is a really useful concept, because it allows you to, rather than say, okay, asthma is all one disease and there is one pathway and one guideline and we're going to stick to it, it allows us to think more about, well, what is driving the disease and what treatment is likely to work and what things are less likely to work. It's a realistic medicine approach. It allows us to target treatment towards the individual, but also allows us to take away treatments that are not going to work. So you've mentioned allergy already. So some people, their disease is driven very much by allergy, and antihistamines, montelukast, and treating the nose because of hay fever, that is a sensible target. But in people who have absolutely no allergic symptoms at all, they have twitchy airways because of the cold weather, or they get lots of viruses, it's not useful generally to pour in lots of antihistamines and lots of montelukast, because the pathways that are triggering their asthma is unlikely to be due to histaminergic reactions or leukotrienes. Other treatable traits are things like body weight. Very important. We've known for a long time that increased BMI leads to a poor outcome in asthma. So that's a treatable trait. That's something we can target to improve outcome. Deconditioning, similarly, is something we can target. Multimorbidity. Other things outside the chest are important. Treating the nose, really important. Nasal polyposis, allergy, very important. And then we get down to treatable traits within asthma itself. For 20 years plus, we've looked at biomarkers. Can we find something we can measure that tells us what type of asthma is going on? What is going on in the epithelium? And ultimately, it's come down to the eosinophil as being the biggest driver, the thing we can measure most easily. 20 years ago, Ruth Green in Leicester published the seminal paper looking at sputum eosinophils, showing that if you target your treatment against sputum eosinophilia, then you get much better outcomes. The problem with that paper is that it's very hard to reproduce because counting sputum eosinophils is difficult. Getting sputum out of people who are relatively stable is difficult. And then counting the eosinophils accurately is difficult. And it's certainly not something you do in primary care. But it turns out that actually your blood eosinophil is just as good, if not better, at predicting what your phenotype is. And if you're an eosinophilic phenotype patient, then treating with treatment which is specifically targeted towards the eosinophil works very, very well. And that's really been the sea change in how we look for our severe asthma patients, how we target them, and how we treat them, and how it can be very effective. Other phenotypes, so we talk about allergic, there's eosinophilic, there's the allergic eosinophilic, so they have both. And then you have pheno. So we've talked about pheno already. So pheno is exhaled nitric oxide. And a lot of work went on into pheno in the mid-noughties because it was felt to be a test that could be done which would reflect sputum eosinophils, but in a way that you could measure very straightforwardly. And looking at alveolar nitric oxide and then looking at nitric oxide flux. And ultimately it came down to pheno being the easiest to measure and most reflective of inflammation in the airways. It's often eosinophilic, it's not always. And by measuring pheno, it gives us extra tools in how to treat patients. So I think what we tend to think about phenotypically, asthma epithelium, is those patients who have allergic disease, those who have eosinophilic disease, and those that have pheno-associated disease. We put all that together and call it Th2 high disease. It's driven by the Th2 T helper cell system.
Thanks. That covers a lot of different types of traits that you've thrown out there. And I think a really nice way that those fall naturally into, as you were describing them, is an approach that I'd come across from a team in Australia, the ABC approach, assessing the airways. So I suppose that's, the inflammatory aspects of the asthma itself, the behavior, so behavioral components, things like smoking or adherence, and then the comorbidities. So as you mentioned, things like obesity or indeed COPD. I suppose asthma COPD overlap is a particularly tricky area. I think the point you made about identifying treatable traits to target treatment, but also to step down treatment is really important too. I find in asthma clinics that if I was looking at the pheno, hoping that I'm going to find a T2 high phenotype because that's relatively straightforward to treat. And then you feel a bit dispirited when those things are negative and you still have a breathless, wheezy patient. But on the point of BMI, if we keep giving steroids to these patients without any discernible benefit, then we're actually actively doing harm. And if we want to try and tackle the patient's BMI as one of the treatable traits and making it very clear that they do not have an inflammatory phenotype and we should pull back on the steroids can be very positive. So I think it took me quite a while to turn my thinking on its head and think about reducing the harms that we do as well.
I think you're absolutely right. And you mentioned there that you're hoping to find a Th2 high patient. And I think we all feel that because there's now something we can do about it. In my head, when I'm seeing an asthma patient, I have a box. And in that box, on the y-axis, I've got the amount of inflammation that they have, or their Th2 score. They're Th2 high, Th2 low. And on the x-axis, I've got the amount of symptoms. So we have people who are very symptomatic, who have got lots of inflammation. And that box top right is good for us because we know your symptoms are likely to be driven by Th2 inflammation. We have treatments that we can get that work, and we think we can help you. We have a group on the bottom left who have a low amount of symptoms and a low amount of Th2 symptoms, but that's okay because their Th2 markers are low, their symptoms are low, and simple measures will likely work. Then you've got a group they've got a lot of Th2 signal but not a lot of symptoms. And they're an interesting group because they don't present very often, but they've got a lot of inflammation going on in their epithelium. And that's an interesting group because, well, what happens in the long term? They're likely to be people who develop fixed airflow obstruction because of ongoing undetected inflammation. We know that symptoms are not a very good measure of inflammatory status. There's a disconnect there. So unless we find those markers, we look for them actively, we won't know. And I think that group is the group that probably does go on to get that mixed fixed airflow obstruction problem. The really challenging group, as you just described, is the group that has lots of symptoms, but is not Th2 high, they're Th2 low. Their eosinophils are almost nothing. Their pheno is 10. And their IgE is low. They don't have allergies, yet they're incredibly symptomatic. They present all the time. And what treatment they get is oral steroids because they've got a label of asthma and they get very breathless or they get a cough or they're exhausted or they're wheezy and they get steroids because they've got asthma. And at the beginning of this chat, we talked about how scary an asthma exacerbation is, and absolutely. So you don't want to untreat with asthma. So they get steroids, they feel better, they go away, they come back. So these people typically have multiple courses of steroids a year. They're getting all the side effects of those steroids with probably not a great deal of benefit. And they're a very, very difficult group to treat. Very, very difficult. And we don't have very much to offer. So yeah, that's a real challenge. So you're not alone in clinic, Ben. You're not alone.
Thanks. So on that note, looking through the BTS sign guidelines, there is a section on difficult asthma, and I think perhaps I'd prefer the term you used earlier, which is difficult to treat asthma. And maybe that is what that group of patients is. The guidelines describe it as a diagnosis of asthma, and it exists, and asthma-like symptoms and asthma attacks persist despite a prescription of high-dose asthma therapy, which they describe as high-dose inhaled corticosteroids or continuous or frequent oral steroid use. So, yeah, I think that probably does fit your, I can't remember your axes, maybe your bottom right corner of your graph there. Do you have any other thoughts on how we can help those patients, as the BTS call it, difficult asthma?
It's a difficult group. We call them difficult to treat asthma, and that's for a reason. And I don't want to generalize, but in that group of people, you can see some types of phenotype that crop out. Rika Chowdhury published recently a very nice bit of work looking at the severe asthma registry data to try to pull out the people who are unlikely to respond to biologics, who are unlikely to go into remission, to sort of characterize who these people are and can we predict them. Now, that data shows that the people who are more likely to have lots of symptoms, be Th2 low or not respond to Th2 treatment, are women, and we don't know why. People are obese, and you can think more about why obesity is a problem, and it's mainly due to breathing dynamic. People with neuropsychiatric problems, so people with social challenges, people who live in poverty, and people who have anxiety, depression, personality disorders, and other psychological diagnoses. Very challenging to deal with, very challenging to treat their underlying psychological pathology, but it does make treating their asthma very, very difficult. And then the comorbid group, so people whose symptoms are due to their heart failure or due to their ischemic heart disease and a whole raft of other different things. And then you can also tease out the later your diagnosis is in life often go against you. So if you've actually had asthma since you were 20, but it was only diagnosed when you were 50, and that again pulls us into perhaps they've had a lot of active inflammation going on for a long time and they've got airway remodeling. So early diagnosis. And then the length of time it's been since your diagnosis. So if you are diagnosed and then you get to see a severe asthma specialist very quickly, you're more likely to do better. And I think that's really important as well, that most people sit with their asthma diagnosis for years, if not decades, before they are phenotyped and see an asthma specialist. And even in people who are referred to severe asthma centres, the delay in seeing someone or starting on a biologic is often years. Hitachi Rapani, Gronia and Kona does some really nice work on this, looking at the pathways of how long it takes you to go through different layers of asthma care before you reach definitive severe asthma therapy. And it is measured in years, which I think is very worrying, particularly now that we have treatments that could be life-changing.
Absolutely. Just on that point of treatments, I'm conscious we spent a lot of time on diagnosing the condition and phenotyping it. Perhaps we could talk a little about the treatments that are available and draw out a couple of important points. So I think you had mentioned the importance of having inhaled corticosteroids as the bedrock, and certainly the BTS is very clear on that patients shouldn't really just have a short-acting beta agonist as their only treatment. The NICE and SIGN guidelines diverge a bit after that, a low-dose inhaled corticosteroid, and then what you add in after that. The BTS and SIGN suggest a long-acting beta agonist, and NICE recommends a leukotriene receptor antagonist in the form of commonly montelukast. Perhaps would you be able to just tell us a bit more about the relative benefits of each approach?
I think when the NICE guideline came out last decade and recommended the montelukast as the next step beyond low-dose ICS, I think a lot of us were quite surprised at that. It's relatively cheap. Tablets are easier to take than inhalers are to use, and I can see that rationale. There are studies that have shown that montelukast is non-inferior to doubling a steroid and non-inferior to adding in a long-acting beta agonist, but that group of patients the studies were done in tended to be more an allergic phenotype. And I think this is the problem, is there is an assumption that all asthma is one disease, and therefore Montelukast will be as good as a long-speech agonist will be for everyone who's got asthma. And I don't think that's the case. I think there is a case for giving Montelukast to some people, and they will be the people who have an allergic phenotype and people who very clearly have nasal polyposis or perennial rhinitis, dermatographism, signs of atopy. But the majority of people don't have that sort of barn door sign, and their symptoms are due to the bronchoconstriction, and a long-speech agonist helps with that. The studies from the early noughties that showed that adding a long-acting beta agonist is better than doubling your inhaled steroid dose. Interestingly, if you go back and look at the data and reanalyze for a different primary endpoint, you get a different answer. So the primary endpoint from Optima, for example, was FEV1. So they looked at doubling your inhaled steroid or adding a beta agonist, and which of those gives you a better FEV1, better lung function. And not surprisingly, adding a long-acting bronchodilator gives you better bronchodilation, and that makes sense. But if you go back and reanalyze it for exacerbation, which are generally inflammatory, then doubling your inhaled steroid wins, and wins by quite a margin. And back then, we didn't think about phenotyping asthma in the same way. We didn't think about what kind of asthma you have, and we didn't think about what was the outcome you're after. The MHRA and the licensing said, well, we want FEV1 means everything. Well, now we know it doesn't mean everything. So if your patient at diagnosis has a higher eosinophil count and is not that wheezy, but has exacerbations, then you're trying to reduce exacerbation frequency, and that probably means more inhaled corticosteroid. If your patient has a low eosinophil count and is wheezy a lot and breathless, then that probably means a long-acting beta agonist. And if your patient has lots of atopy, very allergic, Montelukast would be a very reasonable next step. Guidelines are guidelines. They're there to guide you, but all these are licensed and all these are reasonable depending on the patient. But as you mentioned a bit earlier on, if they don't work, you should stop them. And we're very bad at this. We just stack medication burden onto medication so that people end up on 5 or 6 different things. But if they're not working and there's no rationale for them to work, then it's reasonable to stop them because it's a lot to take and a lot to do. The new BTS sign NICE guideline, amalgamating them all, is due very soon. The consultation was meant to be released this week, and we were talking off air just before that it has been delayed by a couple of weeks. So it would have been nice to talk about it, but we generally don't know what's going to be in that yet. And it will be very interesting to see what happens when NICE, BTS and SIGN all come together from what was quite different guidance into modern thinking about asthma. And my hope certainly is that it does take more of a treatable traits approach, gives more options, is less didactic, and gets you thinking earlier on about what type of asthma you have, because no two asthmas are the same.
Excellent. Tom, I think we could talk for hours about this. There's so much to say, and we have barely touched on monoclonal antibodies and other specialist therapies. But I think as an overview of asthma for the generalist physician, that's a really fantastic guide. And I think the point that you made about this approach of treatable traits really does mean that you can use your brain a bit more when engaging with guidelines, that we don't have to just programmatically follow a stepwise approach, but really look at the patient in front of us, because many of those treatments are not for everybody. Tom, I think we'd better wrap up there. Are there any final thoughts that you'd like to share, any parting pearls of wisdom on diagnosis, management, or living with asthma?
I would say perhaps that the era of patients being on long-term oral steroids for maintenance of asthma should be over. And if you come across patients who are on maintenance oral steroids, then they should be referred to an asthma specialist, somebody with an interest, because there are now things that we can do that we couldn't do even 5 years ago. So our guidance here in Scotland is that anyone on maintenance oral steroids, whether you detect that because you're seeing them for their asthma or for another reason at all, they've come into hospital with a broken leg and you discover that they're on steroids, then please refer them on to us, or at least have a conversation with us so we can try and help. And the threshold for biologic therapy is now 3 courses of oral steroids in a 12-month period. So anybody who's had or is getting their 3rd course of oral steroids in 12 months, that should lead to a conversation for why is this happening. We shouldn't accept that repeated courses of steroids are an acceptable management option for asthma anymore. And at that 3rd exacerbation requiring steroids, there should be a discussion of, is their treatment optimized? And then quick referral onto a severe asthma centre, because the longer we wait, the more steroids a patient gets, the more multimorbidity they get, the more side effects they get, and the less likely it is it'll work. So that's my plea, is that for the generalists, anyone who's listening, if you do see someone with asthma, think about optimizing their therapy. Most of it in benign asthma is straightforward. We can optimize the treatment and get better outcomes. And if people who have more severe asthma, look at those steroid courses and have a discussion with your severe asthma colleagues. We're looking for the work because there's something we can do.
Fantastic. Tom, thank you so much for your time. It's wonderful to talk with you and share your knowledge, and hopefully we can get you on another time in the future.
Thanks very much, Ben. It's really a pleasure to talk, and I'd be delighted to come back if there's more chat about biologics or asthma at all.